Okay. Well, good morning, everybody. Welcome everybody to the Training Wheels Off support group for men and women with Parkinson's and their care partners. We're having a guest speaker today. We're having Tim Meakem from the Focused Ultrasound Foundation. He's going to give us a presentation about the latest developments with focused ultrasound for Parkinson's and the benefits, the pros and cons. And at the very end, we'll have, after his presentation and his delivery, we'll have an open Q&A at the end so you can ask him anything you want, except for how much money he makes. Okay. So with that in mind, I'll turn it over to you, Ken, and we look forward to your presentation.
Well, thanks, Roger, and
Or
thank you
Tim,
all for
sorry.
not a problem. I appreciate you all welcoming here, and let me go ahead and pull up my presentation for you guys. My background is I was an anesthesiologist for many years, and I worked with some innovative people. One of them is Dr. Neil Cassell, who started the Focused Ultrasound Foundation. And then later on, after I retired, I was looking for things to do to make a difference, and I came across this job. And the focused ultrasound really started in a very early stage and has been progressing, and it was finally getting to the point where we're starting to do things clinically with people, and he needed somebody to help with that. And so I joined that job about 6 or 7 years ago. So I'm going to go ahead and share some information with you about it, and if there's any major questions or anything, just let me know, and we'll start from there. Let's see here. I'm having trouble getting into it. There we go. All right, let me get rid of the top part. Okay. So first of all, I appreciate Samantha and Roger for hosting me today. And the agenda really is I'm going to talk to you a little bit about focused ultrasound, just so that we're all kind of on the same page for what discussion we're going to have. And then I'm going to say just a brief thing about the foundation so you know who we are and who we aren't. But most of the time it's going to be really talking about the research update for what's happening for the treatment of focused ultrasound, and I'll leave plenty of time for questions. And this is going to be recorded so that if there's some links or some things in here that you want to look at, Roger's going to have that for you later. So focused ultrasound really is still early stage. It's kind of like MRI was a few years back, where it was available, people knew about it, but it really didn't have much traction in the community. But whereas now you look at MRI, and almost everybody's either had an MRI or knows somebody that's had an MRI. It's like that with focused ultrasound, more on the therapeutic side rather than diagnostic side. So it's still known as medicine's best kept secret, and it really has the potential to revolutionize therapy. So the way it's done is like a magnifying glass hitting a leaf, only this is a transmitter that's and it sends ultrasound energy from multiple transmissions, and each one of those transmissions can go through the body harmlessly, and it's only at the point of convergence, in this case for a patient with breast cancer, where all the energy comes together. It heats up that area and thermally ablates it, or in other words, burns the tissue, and does the desired goal. And here's a patient who is being treated for essential tremor, and this is the same target that they use, the ventral intermediate nucleus of the thalamus, that they use for tremor down in Parkinson's disease. And you can see he's a left-handed architect. He's trying to move these jelly beans from one to the other and having trouble. Here's his circulars and straight line drawing. And the target is this spot right here in his brain. And that's what we're going to try to hit. And remember, this is done with him being awake, with no incisions, no burr holes, no electrodes are passed, so minimal chance of infection or anything like that. And there's the target afterwards, and I hope you can see that well. Right off to that left arrow, there's the little target spot there. Here's his after treatment drawings, which are substantially better. And here he is later moving the jelly beans rather seamlessly from one spot to the other. So remember, this is all done as an outpatient. He's has no incisions. There's a whole. It's non-penetrating to the skin, so there's nothing that's involved with infections or hemorrhage or anything like that because none of that penetrates the body, and it has a rapid recovery and can improve cost. And so here's another area that's going on with focused ultrasound. There are several different ways you can use it, but I'm just going to run through a few of these to give you an idea of the scope of it. The blood-brain barrier is a group of cells that line the blood vessels that go to the brain, and they're protective for the brain because if you get like the flu, you don't want to get the flu in your brain, right? So it prevents things from getting into the brain, but it also prevents any therapeutic medicines or any agents we give to get through the brain, and it also can potentially prevent things that are developing the brain that are byproducts from getting out, and that's creating some problems. Well, you can use focused ultrasound to target on the left-hand side. This is the target, and you can see how they targeted very accurately, and they opened it for the contrast material to show in this treatment. And there's a number of different energy levels that we use for focused ultrasound. We're going to spend most of the time on the high intensity end because that's where we're doing the lesioning. And that's the part that's been around the longest and that's made the furthest pathway through the FDA, et cetera. But there's also things we can do at lower intensity, like opening the blood-brain barrier, or even lower still for neuromodulation. So here's another view of those things. We're going to talk about these two things basically, but there's a whole lot of other ways that focused ultrasound is being used to handle a number of diseases that are happening. And here's just an overview from our website that looks at all the things out there, and the pink and the purple are kind of the ones that are furthest along, but there's a lot of things that are still in process, as you can see. And the last point here is if you looked at this, in 2006, there were 3 items that were being pursued. Now there's over 170. An important part of this is that we really get adjacent tissue sparing. So here over on the liver side, you can see this kind of mess of cellular debris over here. And here's a very fine line, and here's the treated normal cells. And this is magnified. This is a 1 millimeter scope here, the same type of thing in the brain. So it's highly precise in the way it targets, which is important. And here's a number of the focused ultrasound devices. This one right here is the one that's mainly used for the brain. And you lay down, and your head is put in a little container that holds it right there, surrounded by the helmet. It's also FDA approved for things like uterine fibroids. This is a patient with a uterine fibroid, and if you're going to go have surgery, it's kind of nasty. And this patient said, I'll have this with focused ultrasound, and she had that treated, and it took some time for resorption after the treatment in her body, but she has no scar and a great result. It's also very helpful with chemotherapy because chemotherapy tends to hit your entire body and has some not positive effects in a lot of your tissues. And it'd be nice if we could target it right to the area where it's happening. Well, there are ways that you can use focused ultrasound and embed the chemotherapy in some agents, and there are many sizes of agents that you can put them in, and then they're still smaller than red blood cells, and so you would infuse those into the patient, and then you can say, all right, now I'm going to treat the targeted tissue with focused ultrasound. So the chemotherapy that's infused in the patient, they stay there. They don't get out into the tissue until they're hit with focused ultrasound. But then when you hit focused ultrasound, those components release their payload right where you want it, and the payload hits the part where you want, and you don't have the big time side effects from chemotherapy. It's also good at targeting kind of difficult to hit cancers. So this is a slice of a patient right from here with pancreatic cancer, and all of this area here is pancreatic tumor, and you see it being treated here where it turns a little darker here, and then it gradually reabsorbs and gets much smaller later. And this is a very difficult disease, but it just goes to show that you can use the energy from focused ultrasound to get at targets that are not easily obtained otherwise. Here's a person with desmoid tumor on his wrist, and desmoids are benign tumors, but they can be very invasive because they typically involve the nerves, and to try to remove them surgically is difficult. But this patient was treated with focused ultrasound, got a great result, and the tumor is gone. And they may recur, but if they do, you can hit it again. Same thing with breast cancer. A lot of disfiguring things happens with treatment of those tumors. Here we can treat it with breast cancer and not have the surgical side effects that you get with conventional therapy. Here's a patient that is a 6-year-old girl that had a tumor in her abdomen that was benign, but it was massive with size. This whole thing right here is the tumor, and they tried to take it out surgically, and they ended up having to abort the procedure because there was so much bleeding. They didn't think she was going to survive, and they decided to go after it and treat it with focused ultrasound. And you can see that they treated it in two parts. That this part right here was done first, and they come back and treated the rest. And she's 9 now. She's doing well, but and it may recur. But the bottom line is that this was something that was life-saving for her, and if it does come back, they can treat it again. And finally, here's a prostate cancer patient. This is all prostate tumor all around here, and it was treated with focused ultrasound, and you have just basically a little nub of left of what's remaining tissue with the PSA beating tiny, and very, very good result. Now, I know you may think this just might be too good. It sounds like, something too wonderful like snake oil. But it's not the case really. It doesn't help anything with major deformities or trauma or blood-borne cellular deformities like these. So it has certain applications it can help with, but other things it really can't. So let me just say a little bit about the foundation. This was again my boss Neil Cassell was involved with some other innovative devices called the Gamma Knife. You may have heard of that, but it was something that took basically 30 to 40 years from when it was invented to when it could actually be widespread available in use. And when he saw focused ultrasound, he says, I can't go through that again. We can't let it take that long to get there. And so he knows that these are some of the impediments that come along the way to try to get a new device through the regulatory process to have it be widely available to treat patients. And so he looked around and he says, there's got to be some better advantage that I can do for this. And he looked hard to try to see if there's some mechanism to help this, but he couldn't find any. So he felt really obligated to invent, and he invented the Focused Ultrasound Foundation. And really what we are is we're a unique medical research, education, and advocacy organization. We're tax exempt, and our entire goal is to accelerate the development of this process and then to make it become a standard of care, and then we're going to go away. And so we have a lot of things we try to do to spread the news about this. And you have a newsletter that we put out, and I'll give you a link to that later in case anybody wants to join. We've had a number of large media placements, and we are continuing to look for more. John Grisham is on our board. He's an active member of our board, and he actually wrote a book called The Tumor, which is a book about how focused ultrasound might be able to help someone who gets a brain tumor in the future. And we know we're not doing this all on our own. We partner with a number of organizations to get the word out, to help fund research that we're doing together. And we feel like this is an important part that we're placing with a bunch of other people that are going after some similar problems. Our budget's about 15 million. More than 60% goes to research. We have very committed donors. If anybody wants to donate, here's our web link, and I'll give you that later. And our whole goal is to try to bust through these obstacles to try to make this be ready to go sooner and faster. And this is the slide that we think about that makes me get up and go to work every day in the morning. If you look at this gray line, the gray line is how long it would take for this to become available and ready for patient care without the foundation. And then we try to move the line to the left of this green line. And when we do that, all of these patients in here that wouldn't get any care if we went by the gray line and we move it to the green line, all of these patients do get care. And that's the part that really makes a difference. So now we're going to talk really about the current research status. And most of this is really going to be clinical trials. Recognize that a lot of preclinical work was done beforehand. So the main study here was the approval for focus on to treat tremor, and the target is the ventral intermediate nucleus. It's the same one that I showed you in the example right in the beginning for the left-handed architect, and it had really good improvement in the scores. The patients had a substantial 62% improvement in their tremor scores. They did have some side effects. Some had some paresthesias or numbness and tingling, and one patient had ataxia, and this was out of 27 patients. So there were some, but they weren't a tremendously large amount. And this is been FDA approved, and it's being covered by Medicare in a number of states. Not all states, 38 states. One thing to note about this is that if you live in a state like Texas, for example, where it's not approved, and you want to go to a state like Virginia where it is, our understanding is if you go to a location where this is approved and your treatment occurs in Virginia, then Medicare will pay for it. Now, we always say you got to talk to the treating site, make sure they understand what you're doing, and make sure they agree with that. But so if you're willing to do a little traveling, you can get the treatment for tremor dominant Parkinson's disease. And this disease is approved, but it's approved unilaterally. So you pick one side that's the worst, and that's the side you got to have it done on, at least right now. One of the things that I wanted to show you, this is kind of a busy slide, but this was a poster that I copied this from, is this link over here where you see the tan line is kind of DBS going over time, and the blue line is the focused ultrasound. So it's gradually increasing. And the other thing that's important here is this section here, which is too small to read, so I tried to blow it up for you. And this talks about the adverse events that come from this. And this is using the VIM target, which again is both for essential tremor and for tremor dominant Parkinson's disease. So you put them together and you see the number of issues that you had was small, but still significant, 4% up to 25%. And over time, in 17 to 21, it's gone down dramatically in terms of the percentage of people that get these issues. And even in 2023, 2023, it's gotten even smaller. And part of the reason for that is that the neurosurgeons, they don't like patients to have these adverse side effects either. And so they've been working hard to try to really get the target where that gives you what you want in terms of the tremor reduction, but doesn't give you the things you don't want in terms of the adverse side effects. And they've really made the target smaller, and it's gotten a lot better. Now, the other part is that there's one of the challenges with Parkinson's disease is not everybody has tremor, right? Some people have different components to their movement disorders, and it's highly variable. So for patients that have motor fluctuations or dyskinesia, which can also include some rigidity or some slow movement, those things are all kind of lumped together, and we're going at a different target in the brain to try to resolve this problem. And the target they were going after is the internal portion of the globus pallidus, or sometimes referred to as a pallidotomy. And they looked at several studies to do this, and this one was 94 patients, and they had a good response. 69% had a response in 3 months, and they did have some side effects, but they weren't moderate. Remember, this is a larger study. A couple patients had trouble speaking. One patient had a visual disturbance. Another one had some facial weakness. Medicare is not paying for this as of yet because this occurred a couple years ago, and the Medicare is a slower process to get its approval, but hopefully it is coming and hopefully soon. It's interesting that even though Medicare typically comes first, and then some of the private insurance companies will come second. We already have Anthem, Blue Cross, and Blue Shield covering this in a fair number of states already. But I need to talk a little bit more about the dyskinesia family because there are many different places you can target depending on what the symptoms are. So it's very important for patients who have a wider variety of symptoms to know what's the best target for me because it may be in a different location. And this is kind of a rough sketch of some anatomy that Dr. Eisenberg was kind enough to share with me. But here's the globus pallidus over here, and the nerve fibers kind of come down and they circle around. Here's the subthalamic nucleus, which is another target mainly pursued in Europe to go after this treatment. The zona incerta is right here, which is another target, and here's one called the pallidothalamic tract, which goes up into part of the thalamus. So there's a number of ways that you can target these various things depending on what symptoms you have. And there's studies on those. So for the subthalamic nucleus, this is done in the same kind of technique. They had pretty good 55%, 52% recovery from baseline, very low p-value. So it's done well at 12 months. They did have some side effects, and they had a lot in the beginning. Some were 15, some were 13, and remember this is a little bit larger study, but it got better over time, but they're back down still having some significant side effects, and that's part of the reason why this hasn't really taken off in the United States. The pallidothalamic tractotomy, or PTT, is another one that it was led in by some focused ultrasound leaders in Switzerland, and they studied that. But there's also been a big study here in the U.S. So they had not just tremor dominant patients, but they had a mix of patients, and a lot of patients had other symptoms as well. But they had a good response, 54%, good low p-value. They did have some side effects. And again, remember, this is a 50-patient study, so a little smaller, but they had some trouble with speech difficulties and soft talking or hypophonia. Now, there was a study where the same technique was done. It's been a mostly done in the U.S. study, and it's interesting for two parts because it was looking at both the treatment of the patient's symptoms, but also they had a staged bilateral part where you could do one side today and and then you would wait for a 6 month period of time and then do the other side. Everything up until this point for Parkinson's disease has all been unilateral, but this is the first bilateral treatment that was done. Now, we haven't had any publication on that yet. We're expecting, and we say expecting kind of with quotes because we can't really predict it very well, but we're hoping that the first half of this year we're going to get some discussion of the results of this study. And also, we believe it was a large enough study that it's probably going to go to FDA action, and FDA may approve this for unilateral or bilateral treatment, but we're waiting to see that. So we're watching for that, and this is probably one of the biggest reasons why you may want to sign up for our newsletter, because when we hear about that, we're definitely going to put it out in the newsletter so that everybody knows. Now, a couple of things to note. One is that the symptoms did not completely resolve for these patients. You know, they got a 50% or some, and that's important to know because one of the things that the neurosurgeons are doing with this therapy is they want to give you the best benefit they can give you, but they don't want to give you a lot of those side effects. So a lot of the patients say, you know, we don't have to treat and wipe out my symptoms completely if that's going to give me more side effects. And so they're trying to balance their treatment to give them the best of what they want without getting what they don't want. And the other thing that's important about this is with the ongoing progression of the disease, you know, Parkinson's disease gets worse over time. And we may have a good treatment and patient they say they have a lot of tremor in their one hand and they make that tremor treated effectively. But then the disease gets worse and worse, and then eventually the tremor starts to recur. Now, we're watching for that because we know that is something that it is possible, but it's this treatment's been going on for 4 or 5 years and really haven't seen that very much yet. Now there's still people looking for this and doing evaluation. People have done studies saying, you know, what happened over time to try to watch for this, and we haven't seen um, recurrent treatments or stuff in the literature. Now, the one thing about this is, you know, with some treatments in the brain with radiation, you get a certain maximum, and that's all you can have. But with focused ultrasound, you can have repeat treated if you need it, and there's no issues with that. But like to say that that's something that we're watching for and seeing because it is a possibility that might happen. So the next steps for the movement disorders really we have a few things that are still being worked on. One is bilateral treatment, and the question is it needed to use the same technique for both sides, or what if we targeted different parts for the dyskinesia, and could that be better to help with that? And is the staging even needed at all? I mean, the reason that the staging was done was just out of an abundance of caution, because when they were doing this with open procedures, and they, you know, obviously wouldn't want to go into your brain twice if we didn't have to. They would do both sides, but when they did both sides at the same time in an open procedure, there are a lot more side effects, and so they're trying to just be very careful with this. But maybe we don't need that staging eventually. The other part is what size lesion is optimal. Now, I talked about this a little bit with that slide, but if we can decrease the targeting to just get what we want and have less side effects, that's the ideal goal. But trying to work that balance, we're having the small enough target, but yet still being effective is still in process. And part of that relates to the point number 3 is what's the optimal targeting technique? When these started, they were all done with using the traditional coordinates, which are some bony structures, and they say on a map of everybody's brain that this spot here is where the target is, and so that's where I want to go for this global map of lots of people. but everybody's brain is not exactly the same. And so they've developed this MRI tractography where you can actually track where in me, the patient, where in my brain these things go, and we can say that we think this target for you is right here, and maybe it's a little bit moved a bit from where the traditional coordinates point to the target for everybody. And so most people now are looking at the MRI tractography and the traditional coordinates, and they track them both, and they say, okay, this is the traditional coordinates, this is MRI, and it helps guide them their targeting to be the most effective. And I think that's still getting better with time, and I think it's one that is partly contributing to that slide that showed that we're having a lot less of these side effects than we had initially, but I think there's still room to go there on that. Um, Now, up until this point, we've talked about really just the high intensity focus ultrasound for creating an ablative lesion, the burning of a lesion here. But one of the other things about this process is we can use focused ultrasound to try to get at the underlying cause of the disease and really try to say, how can we stop Parkinson's from happening entirely? And this one is more using the focused ultrasound energy to temporarily open the blood-brain barrier. And the idea here is if you can get the blood-brain barrier to open up to allow therapeutic agents to get in there and treat the disease, and these could be agents of many different sizes. Some people have trouble with an enzyme getting in there. Other people have the reduced production of dopamine. We want to try to see if we can solve the problem. And there's two major groups that are doing this. One group in Spain and another group in Canada. And the group in Spain really is used the blood-brain barrier disruption to target the putamen and really where they believe a lot of this starts, and they're doing a lot of this in these patients. And they've made some very good progress to the point where we're actually funding them to do a large animal study of trying to put in a a venous a, a venous analog which will produce some components that would solve the problem of Parkinson's disease in these animals. And if we can do it in these large animals, we can probably do it in a person. So we're working very hard to see if we can push that forward to get at the disease. In Canada, they're doing a little bit of a different study. There are these patients that have Parkinson's disease, but they also have a reduced enzyme, the glucocerebrosidase, that is helps with their metabolism. And this enzyme is big enough so that it won't, if you give it IV enzyme, it doesn't go across the blood-brain barrier because it just won't get across. So they have this IV Serazyme, which is the modeled after the glucocerebrosidase that they can give with the blood-brain barrier opening and have it get in there and help that. And that's moving along nicely in Canada. The overall goal here is not to try to stop the development of these patients. So this is one group here where they were patients with moderate dementia. We're not really trying to use it to interfere with dementia. We're trying to use it to get to the spot to actually stop Parkinson's disease entirely. And this is the latest study that was put out. This is from the group in Spain, and they're working right now on trying to get that AAV vector delivered into the large animals. So in terms of going after the underlying cause, there are even more questions. One is what agent or agents is best used here, And then how long does it last? Does you need multiple injections or not? And then what is the timing? Is it treated once a day or once a month or once every 6 months? We really don't know for that yet. But all those things are in the process of trying to be worked out if we can find the agent that seems to make a difference. So one question comes down here and says, what is the best thing for me? Is it um, DBS or focused ultrasound? And it really isn't a question of right or wrong. It's more of a decision to make. And the biggest decision factor from what I've seen is that a lot of people don't want the invasive nature of DBS. They don't want the holes drilled in the brain. They don't want the fact that you're passing those electrodes through perfectly normal brain tissue to get to the target that they want. And they prefer not to have the battery packs in place and those have to be replaced. And the fact that whenever there's a foreign body in your body that the foreign body can host infections and cause problems with that. So a lot of people for that reason say, I don't want to have the DBS, so I would prefer to have focused ultrasound. But the other part of this is you have to think about, how conservative you are or aren't in pursuing this. And the reason I say that is because if say you wanted to have DBS and this procedure done, and you have it done, but for whatever reason you don't like it, and you say, I want to go back to the way I was before. Well, you can do that. You can pay to have the electrodes removed, the battery pack removed, and go back to essentially where you are before, as long as there wasn't any major, infection or complications like that with DBS. But you can't do that with focused ultrasound. Focused ultrasound is an ablative treatment, and once it's done, you can't say, I want to undo it. It's there. And the results have been good in many ways, and people are happy with those. But if you're one of those people on that list that has one of those bad results, you live with that too. The other factor that comes in here is DBS, you generally have to have more interventions and surgeries because the battery packs do need to be replaced. And a lot of times you have to go in and see the neurologist to adjust and tweak the DBS electrodes to try to get the optimal results from those. Whereas with focused ultrasound, you really don't have those things that you have to happen. It's basically it's done, and they don't have to repeat it, except if you have bilateral disease, you might have to have two treatments for focused ultrasound, where as DBS, you could have it all done at once. So that comes down to kind of the decision making on that. Let's see. Okay, there we go. And so, what do you do if you're interested in focused ultrasound treatment? Remember, there's no issue in learning about what's available, even if you decide it's not for you. So I welcome people to try to find out about this and talk to someone and see what they think, and then they can help make a better informed decision on that. And so if your movement disorder is predominantly tremor, then the thing to do is to go this is the link here for the insightech.com website of all the approved places, and find a spot that can give you information about what they can do for you and what the risks are, so you hear the full side of it, and then Now remember, for Medicare coverage, you may want to have your treatment done in one of these states, so that it's covered. And if you don't have just tremor, say you have the bradykinesia and rigidity and the dyskinesia kind of family of things, that's a little harder because right now, if you have the capacity to cash pay for this, and it's not an inexpensive thing, a ballpark figure is around $40,000, then you can do that. But most patients are going to say, I'm gonna sign up for our newsletter, and I'm going to wait for this to get approved by Medicare, and I may have to travel a little to get it in one of the early spots, but I'm going to do that, to try to get it done. The other thing is you may want to sign up for the newsletter to see if there's some additional alterations with that PTT being potentially and approved by the FDA, and especially if you have bilateral disease, you may want to do that as well. That's just so you're aware of what the latest thing is for that. Well, and if I was going to have focused ultrasound, what advice would I would share? Because there are a couple of components. One is the head shaving. This is still needed, and the reason is because when the ultrasound energy hits tissue air interfaces, it distorts it, and you lose energy. And so we still need to shave the head to do this today. Um, and this is especially a problem for the ladies, and it's not as much of a problem for me. But if you, the recommendation I've heard is to get a short haircut and have a wig made based on the shorter hair, and then you have less time you have to wear the wig. Um, the other challenge is for people who have claustrophobia, because this takes a couple hours in the MRI machine to have this done, and people with claustrophobia say, I don't think I can handle that. And I would truly try to assess where I am with this. And we had some people that have used some kind of mind control things where they try to, think about things and get used to being in that tight space before they go in so that they're better able to handle that. But claustrophobia may push you to a DBS. And I say that because most DBS physicians would prefer you to be awake as well, but they will do it with sedation. I would not want to be significantly sedated during my treatment. And the reason is when you're in the MRI and they're doing those test sonications to identify what's the best target for me, they're going to be asking me a bunch of questions. Do you see any blinking lights? Do you have any numbness in your cheeks? And I want to be aware and awake and answering those questions in the best capacity I can because I want to try to avoid having the side effects. So that's one you really got to think carefully about as you're going to do this. One other thing I'll just share to you, John Dutton is a Parkinson's disease patient who had a focused ultrasound done for a tremor, and he's an artistic guy, and he made a film about it. And it's worth the time to watch. It's a little bit of a longer film. It's probably maybe 30 minutes or something like that, maybe 45. But it really goes into the details of how they do it and all the procedures. And it's if you have questions about it, this is something that's worth the time to watch. Um, and now I'm going to put this screen up here on the end because we're just about done. So now we're just going to go to the questions. I'm going to put this screen up here in case anybody wants to copy down John Dutton's video here, our treatment site locations for the Insight Tech is here, the newsletter. And if somebody has any questions they want to email me specifically about, there's my email address. So I'll leave that up for a second, and then I'll see if anybody has any questions.
Well, thank you, Tim. Would it be possible to get a copy of those slides as a PDF, maybe?
Yeah, I can send you a copy of those slides, sure.
Great, because that way I could send out all the links as well. Because I usually do like a follow-up email to the group.
Okay.
Uh, so as a follow-up. So thank you very much for your presentation. If you want to take that down, I will spotlight myself again. There we go. So we open it up for question and answers. You can either raise your hand virtually or you can raise your hand physically, and I'll try to find you. Robert, go ahead. You can go first. Robert
Yeah,
Stoll.
thank you very much. A very excellent and very informative presentation. Thank you very much. I have two questions. Question number one is about risk of stroke. If you kill cells, then presumably they will get cleaned up with the bloodstream, but you didn't mention stroke much.
Yeah,
So
I'll take them one at a time. That makes it easier for me too. There was a lot of concern about what's going to happen to the target and is there a risk of stroke, and it's been a big issue, not just for the ablative procedures, but even for the lower procedures in terms of how they're going to treat that. And they were trying to do this for some improvement of patients with brain tumors and things like that. And the bottom line is they haven't had any problems with stroke that I have seen that have been reported. And everybody's looking for this with dealing with the Parkinson's disease, both in the tremor and for the dyskinesia one. Now, that's you can never say never, because that's just not the world we live in. But we really have not seen any issues with that coming from this treatment. And I think part of the reason is they're they're heating it up internally, and it they're they're not targeting areas with lots of blood vessels and things like that. When the target that they're picking is one that is not akin to large vessels and downstream debris falling and causing a stroke. Now, that's again, not to say that it could never happen, but we have not seen that in the results from this.
But and my other question is about mapping and accuracy. So how is the mapping done? Is that observing the structure of the brain, or is that following electricity currents, in movement or whatever? How do you um, pinpoint this area that you need to
Yeah.
treat?
Yeah, and then the answer is it's both right now. Right, I mean, right now there's I call the generic map, where they say we've have, lots of people that have had either trauma or other things wrong with their brains, so they know in what portions of your brain these types of things are generally identified. But my brain is different from your brain, somebody else's brain, and we try to put together the atlas of everybody's position out there, and it's reasonably close, but it's not for me if I'm the patient. And so that's where this stuff where they go, the MRI tractography is, they use MRI to try to identify where the targets are specifically within me. And so then what most places are doing now is that they will use their their kind of the old school bony lesions, and how many millimeters from this over, and my target is right here. But then they use the MRI tractography to do that same type of thing in me and say, his target is just a little to the side of this one. And then and this is why those neurosurgeons, it's challenging to say, okay, how much do we go, where do we go, and to pick the target. And I think they're getting better at doing that, and that's why the side effects have gotten so much smaller. And when I talk to the neurosurgeons that do this, most of them say, I've my trend in treating patients has to make a smaller lesion now than it was 3 years ago.
Yeah,
And so they're trying to do this smaller lesion, but I think it's still a work in progress, because most places are saying, I still want to see both.
right. Interesting. Thank you very much.
I had a follow-up question too to that, Tim. I just was curious if you do get the ultrasound done and later on you find that didn't do the job, would that impede you getting DBS?
No, from my understanding, that it doesn't stop you from getting DBS. Now, the one thing, if you're going to go the other direction, if you're going to have DBS first and then then say it didn't work real well, or you'd have to have all of the hardware removed to have the focused ultrasound.
Okay. I'm gonna just ask another quick question while I'm got you on the line here. Do you have any idea why Florida hasn't approved it for Medicare yet? Because I live in Florida. That's the reason I asked.
Yeah, Florida has been on the slow end of approving things for a while. Remember that this technology is also approved for treating essential tremor, and now it is approved in Florida. But when we were going through things like I don't know if it was exactly right. It was like 48 states had all approved this, and Florida was not. And it was the process by these Medicare audit contractors who don't really, they don't really listen to me or anybody else. They have their own kind of agenda. They were slower, so it doesn't surprise me that they're slow in the Parkinson's part too, because they were slow historically on this.
Yeah. Well, we have a Surgeon General who said that you don't need to get vaccinated for COVID either. So I might explain some of the logic for it. Okay. Anybody else have a question? Raise their hand. Oh, go ahead, Ken. I
Yeah,
unmuted you.
yeah. One of the technology I'm looking at, they approved it in the UK, and they know how many people have this device, and it's like 3,000 people, and they track how many people return it because the results are not good, or and how many people keep it. Is there any foreign country that's approved this, and is there any methodology for tracking how many people have done this so far?
Um,
Hmm.
well, we that one study I had they have some cumulative numbers of people just because everybody who's been treated with focused ultrasound, they all basically are the only approved manufacturer right now is Tech, and they keep track of their data, and so they have that type of information, and I don't actually recall it, what number we're at, but it may have been in that slide that they told me how many people have they actually done. I think it was up around 10,000,
Oh,
um,
oh, okay.
but don't quote me on that.
But
Um,
that's a good number to know about.
yeah, well, and the part of the reason they did that study is because the they have the data on all these patients, because all the patients are treated at different places, and even today the people don't pull their data and very easily, so that they can go back and track and see, and because they've been working obviously with the neurosurgeons to not have all these side effects, and they wanted to show that they're really making progress in that, and it was very encouraging to see that trend.
Hmm. That answer your question, Ken?
Yeah. And what about foreign countries that approve this?
Yeah, it's approved in Europe and in Asia. I have a list here, but it's uh, it Europe and Asia, um, and I think in different countries in even South America. There's a couple in South America. It's it the part of the challenge with this is it's not an inexpensive bit of equipment, and so like I don't think there's very many in Africa, and but like they just had a site open in India, so it's growing. But part of the problem is that if you need to have the neurosurgeons that want this, and that's not as big of a problem. But then you need to go to a facility that's willing to spend the money to get this, and it's probably maybe if you have the right type of MRI that they can attach the MRI to this, it's still probably a $5 million project. And if you don't have the right type of MRI, because if you're in an older place that maybe you haven't upgraded your MRI, then it's more like a $7 million project.
Some big numbers.
Yeah, well, and the other factor that comes into this is that in these especially rural hospitals, MRIs are a money-making machine. They want to get people through and treat them and stuff like that. And now you're going to say, I'm going to take my money-producing MRI and move it to a less money producing mode when I'm using it with focused ultrasound, because you don't it takes 2.5 to 3.5 hours to do some of these patients. You can get a lot of MRI scans done in 2.5 to 3.5 hours, and so it's not it's a that part is a cost decline for the
Yeah.
hospital, and that makes it very hard for them to want to do.
It's like an Uber driver who wants an expensive route rather than a cheap route.
Yeah.
Yeah.
Thanks for sharing that. Edie, you had your hand up? Go
Yeah.
ahead.
How is it determined if a person's a candidate for focused ultrasound, and is there a window of opportunity that you need to kind of fit into?
Yeah, good questions. The biggest reasons not to do this are things, if you had, metal implants or something that is, metallic items that prevent you from having the MRI. That might be a reason not to do it. The 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 um the nice thing about this is it's really designed so it's the biggest problem for a patient is just, can they lay still and in the MRI scanner for a while, because it's non-invasive, so you don't have all of the anesthesia components for, is their heart and lungs going to be up for it, can they stand up to it, all that stuff. You really don't have that issue, and it comes down to the some people say, well, is mine bad enough for me to have this done? And it really turned that question around and say, how much is your quality of life being limited? And it's the type of thing where, I've had patients that have said, I can do everything I need to do, but the problem I have is that I don't want to go out and do things with anybody because I spill drinks. I can't. The tremor problem was limiting significantly their quality of life. And this person liked to go out and do all these things. And this is a single person, so she's now living life all by herself because she doesn't want to go out. And it's like, then go do it. And it's really a personal decision to do it. It's not a it's not one where I, at least from the physicians I've talked to, where I talk to them and say, this person's interested in this, and they want to chat with you about having this done, and they say, no, you're not bad enough to come back later, because if it's impacting their quality of life, that's a significant portion.
Thank you.
That makes sense.
Mhm.
It was interesting when you were part of your presentation, you were showing about focused ultrasound for opening up the blood-brain barrier. I was watching a video of or a story about the guy who basically invented DBS, who's now using that technique to introduce Alzheimer's drugs into the brain that normally won't pass through the blood-brain barrier. You think that they'll eventually maybe do that for some Parkinson's medications?
Well, that's what we're working on, particularly with the group in Spain. They really think that if we can get this AAV, which is an adenovirus that produces a variety of things, including dopamine, that we can and get that into the key part in the subthalamic nucleus where all this starts, that we may be on to not just making the tremors better, but curing Parkinson's disease. And boy, that would be wonderful. I mean, I'd love to see that happen. But it's like everything. It's got to work through the process, and this one's taken a lot longer than we had hoped.
Sure. Thanks for that. Sue, you had a question?
Yeah, I was wondering if a person down the road was interested in getting FUS, how would you know which doctors are better than others? How would you, because just like any surgeon, some are better. How do you find out their history with the success rate with this technique?
Yeah, that's a good question. And part of the problem is I get asked that question all the time because and what I can tell you is that once it's been approved, then we don't have any data to really compare one person versus another. But what we can say is that it is important to know that there's a learning curve with this. And so I what I tell people is I would ask the physician, how many of these have you done? And when you're asking for Parkinson's disease, you really they can probably will want to include their essential tremor treatment because they're going at the same spot, and that's fine. But and it's like anything else. You do the first 20, and that's different. They say I'm number 16, then I'm number 116. And I think it's helpful to make sure that they've got some experience in doing this and going forward. Now, what number is the magic number to say is it okay? I don't know. We don't know, but I generally look for people that have had some experience doing this.
Makes sense.
Okay, so when they're doing the actual procedure, the ultrasound, I know with the MRI, you have that like helmet on that keeps their head steady. Is the same thing with the ultrasound because obviously with people with Parkinson's, they tend to move, different degrees depending on their stage of.
Yeah. And just so you know, when they're doing the procedure, you'll have this it's kind of a frame that they put on that is actually bolted into your brain a couple of spots. So it's hold still, and that frame is secured in the MRI scanner, so you can't move. So you're as still as you can be. That frame is secured to you, and it's tight there.
Like a halo.
Yes, ma'am.
Okay,
Yeah.
thank you.
Uh, Chris Romanek, you have a question. Go ahead.
Yeah, can you talk about the procedure for testing the skull density ratio?
Yeah. The skull density ratio is another variable that comes into this. And just for everybody out there, my skull might be thicker than somebody else's skull, and there might be thinner, and the amount of bone that you have to put the ultrasound through is important because bone really absorbs a lot of this energy. And there are some people who have too thick of a skull so they can't get enough of the power through the bone to get to where we want. And so we can see what we want, and we target it, but we just can't enough power to treat it. And so they have this calculation where they do a CT scan, and it's a special type of CT scan where they're looking at the bone thickness, and they're calculating how thick it is and how far you're going forward, so they can generate this number, which basically is my skull too thick or not too thick to have this done. And some places are very firm and say if your skull density ratio is not bigger than 0.4, we can't do this. And the other ones will have say, well, this is not a hard and fast number, but they need to talk to the patient and say, look, your skull density ratio might mean that your skull is too thick for me to get this there. Now, it's close enough, and they can talk some numbers about this, but they say, I'm willing to give it a try, but you need to understand that we just might not be able to do this because it may not get there. But there are some patients, and there have been some studies done on this, where they have done the patients whose skulls were arguably thicker than the target, and they've been able to successfully do it. So I'm willing to give it a try if you are, and if you wanted to do that, you can talk to the physicians that'll do that and see if they can treat you. But that's the issue is kind of your skull might be too thick to allow the energy to get there to effectively do the treatment.
What is the cost of that, and does insurance normally pay for that test?
Yeah, I don't know about the insurance paying for the test. I mean, CT scan is not terribly effective, but they do a lot of thin slices, so it might be a little bit more. Um, and uh, I don't know if insurance typically would pay for that or not.
Mm.
But the
So you
cost would
call,
be maybe about a
no, go ahead.
thousand.
Yeah, I mean ballpark. CT scans are generally cheaper than having an MRI scan. So I mean, I always hesitate to quote numbers because there's such a wide variety of things there. But my guess would be it would be in that range or smaller.
Okay, thank you.
Yeah, I would think that the surgeon would hopefully be able to code it in such a way that the CAT scan would be paid for by insurance. But they have to be creative when it comes to the way they code different procedures that are done. So yeah, good
And
question though.
one thing I want to also say is because a lot of people might have Medicare or might be on a Medicare Advantage plan. And remember that the idea with Medicare Advantage is that they're gonna give you kind of less of Medicare than what you normally have, but then you're going to get to pick up some other things. And we have had people that were very upset when they found that their Medicare Advantage plan wouldn't cover this, and maybe they wouldn't cover the CT and stuff like that too. So just be careful when you're looking for those Medicare Advantage plans
Yeah,
because they're
that's why
really
I just turned 65 and I switched from Medicare Advantage to Medicare because that's one of the main reasons that Medicare is between you and the doctor, as where Medicare Advantage is between you and the insurance company, and they can deny you. So something to keep in
exactly.
mind. All right. Any other questions? I know we're past the 12:30 mark, so I don't want to keep anyone if they got to go, but just want to see if anybody else has a question. If not, we'll say thank you very much to Tim for coming today. We really appreciate it. If you could send me those slides, I'll send them out later with the links that he wears in his presentation. And we really appreciate you coming today.
My pleasure, Roger. And I'll send you the slides. I may have to break them up because sometimes the slides are a little too big, but one way or another, I'll get them to you.
Great. Thank you so much.